Great. Well, thank you for having me. It's going to be a two-part presentation. First, I will go over the surgical management because I am a breast surgeon, and then I'll have Dr. Jayachandran come up, and she'll go over the medical management. So early stage breast cancer, first I just want to say welcome and thank you to Bay Area Cancer Connection for inviting me to speak. I'm very excited to share the latest information with you about breast cancer surgery in patients and survivors and their loved ones. A little bit about me, as you already heard, I'm a breast surgical oncologist at El Camino Health. That means that I'm a surgeon that focuses on breast cancer surgery. I've completed specialized training in this in a fellowship at USC. Okay. Today we'll be talking about the latest updates in breast cancer treatment. Particularly, we will be discussing the de-escalation of breast cancer surgery in some particular populations. Also, there is a trend towards multidisciplinary approach to breast cancer treatment, and because the care for breast cancer has gotten so complex these days, and so really it's being tailored towards each individual patient. And then we'll talk about a turn towards quality of life because more and more patients are living after their breast cancer diagnosis. So some recent numbers that show that the 5-year survival rate for localized breast cancer, meaning breast cancer that has not spread outside the breast, is close to 100%. And the 5-year survival rate for regional breast cancer, meaning breast cancer that has spread to nearby structures such as lymph nodes, is 87%. These are really amazing numbers, showing that the research in the breast cancer field is robust, and it's paying off. So more and more people are surviving from their breast cancers. I think it's important to discuss the history of breast cancer and where we've come. So the first breast cancer surgery was performed in 1982 by William Halsted, and it was called a radical mastectomy. They basically removed the entire breast, the pec muscle, and then all the axillary fat underneath the armpit. So as you can see here on this patient, it really exposed their ribs, and it led to deformity, and they were unable to use the arm on the affected side. So this was the only way they knew how to treat breast cancer back then. But over the years, others have thought, what if there was a way to treat breast cancer that was less morbid and less deforming for the patient? So from that, the modified radical mastectomy was born. It involves removal of the breast tissue, but leaving the pec muscle underneath untouched, still removing all the fatty tissue in the armpit. Studies were done comparing the radical mastectomy and the modified radical, and they saw that the survival was the same between the two. So if we could do less disfiguring surgery on patients with the same results, why shouldn't we? In 1985, they also thought, what if we could do even less surgery? So what if we only remove the cancer in the breast and leave the rest of the breast itself? That's called lumpectomy or partial mastectomy. And they did studies, and this showed that the lumpectomy plus radiation survival was equivalent to those that had a modified radical mastectomy. So even to this day, we still counsel patients that are lumpectomy candidates, that the survival between a mastectomy and a lumpectomy plus radiation is equivalent, as long as they agree to receive the radiation and the subsequent medical therapies. So as you can see, over the last century, we've had a lot of decreases in the amount of surgery that we do with similar or even better survival results. It's important to discuss the breast cancer surgery and discuss the lymph nodes. So we have many lymph nodes that live in our body. When we talk about breast cancer, the ones that we primarily care about are the ones that drain the breast. So these are called axillary lymph nodes, and they're the most common site that breast cancer tends to spread to. And so when we think about these lymph nodes and lymphatics, these are the highways that drain the fluid and cells from our breast, but also from the arm. And so as many of you guys know, axillary surgery can cause lymphedema, so we do worry about that. And the big picture on the bottom left is lymphedema, in case no one has ever seen it, but I'm sure lots of you guys are familiar with it. So there are primarily two types of lymph node surgeries that we do. We do a sentinel lymph node biopsy, and that means that we inject a radioactive substance or dye, and we use a special probe in the OR, and we find the node that has taken up the substance or dye. We remove this lymph node at the time of surgery, and we send it to our pathologist, and they look at it under the microscope and tell us if there's cancer in this lymph node or not. The chance of lymphedema in this case is 5 to 10%, so not zero, but pretty low if we're only removing a couple lymph nodes. Axillary dissection is the other type of surgery we do in regards to lymph node surgery. This is where we completely remove all the lymph nodes in the axilla, and this is done if we're concerned that there's multiple lymph nodes positive and that they may be harboring cancer. So we're gonna wanna remove all of them and have them examined by pathology. When we do this type of surgery, there's about a 30% chance of lymphedema. So the risk does go up with the more tissue that we remove in this area. Okay. So for a very long time, sentinel lymph node biopsy is the standard of care when it comes to breast cancer surgery. We want to check the lymph nodes under the microscope to make sure there's no breast cancer there. But we also know that there are significant side effects with axillary surgery. So if we're doing a sentinel lymph node biopsy with a lumpectomy, it's often through a second incision that leads to more pain and delays in wound healing, and sometimes it can cause motion restriction, in addition to causing lymphedema. Okay. So the background was important because there's 2 studies recently that looked at de-escalation of axillary surgery. The first one was published in 2024, in March of 2024, called the SOUND trial. And the second one was published in December 2024, called the ENSEMA trial. So both studies had over 1,000 patients enrolled and were prospective randomized control trials. And so this is the most rigorous type of scientific study when we are looking at scientific studies, and it is the gold standard when we use to examine cause and effect relationships. Both studies saw no difference in 5-year disease-free survival between those patients that had the sentinel lymph node biopsy and those patients that didn't. And also they saw no differences in 5 years for the distance disease-free survival and overall survival in both groups. Okay. So what does that actually mean for our patients? The conclusion from these studies are that some women with early stage breast cancer, so the criteria is that it has to be a small size, less than 2 centimeters, and hasn't spread to lymph nodes yet, meaning they'll do an ultrasound of the lymph node before you get any surgery to see if it looks suspicious or not. These patients also have to have hormone-positive breast cancer because the study was done in hormone-positive patients. And then if you meet these criteria, you could potentially forego sentinel lymph node biopsy. And this is such a breakthrough in breast cancer surgery because for so many years, we have been always defaulting to sentinel lymph node biopsy. But if we do less axillary surgery, it means less pain, faster recovery, lower risk of lymphedema for our patients, better use of the arm and range of motion. I would like to add a caveat that this is only data from 5 years, so we know that breast cancer can recur in 5 to 10 years, so we would like longer follow-up on this. And breast cancer care is very individualized to each patient, so I encourage you to talk to your providers in a multidisciplinary setting to see if this is a good fit for you. Another surgery that is along the same lines of de-escalating things in the axilla is the study called B51. It looked at omitting nodal radiation, meaning radiation to the armpit, in patients that had lymph node positive disease pre-surgery. So if you can follow along with me here, because there's a lot of steps to qualify for this. So first, we'll just talk about the results. It was, again, a prospective randomized control trial, which I'll emphasize again is the highest standard for scientific studies. They, again, had over 1,000 patients in the study, and one group received radiation, and the other group did not, for patients that had already a diagnosis of a lymph node with breast cancer. And they underwent neoadjuvant chemotherapy, and then they went surgery. So at the final time after surgery, when we removed the lymph node, we were able to see if it had cancer or not. So patients that in this lymph node removed at the time of surgery did not have cancer in it. Half of them could omit radiation, and the other half would receive the standard, which is radiation to the armpit. So they saw that there was no difference in survival and recurrence and distance recurrence. So all very good things that we've already kind of talked about. But when they did subgroup analysis, they did see that there was a difference in hormone receptor positive breast cancer patients and triple negative breast cancer patients. And again, this is a 5-year study, so we would like to see longer results here. Right, so kind of going over the conclusion from the study was that for patients with breast cancer that had initially positive lymph nodes and were treated with neoadjuvant chemotherapy and then had surgery to remove that lymph node, if that lymph node removed at the time of surgery did not have any cancer cells in it, they could potentially avoid radiation to the axilla. And again, that is less risk of lymphedema, increased range of motion, less pain, because you're doing less treatment to the armpit. I do want to differentiate this with radiation to the breast. So it does not talk about radiation to the breast. This is just radiation to the armpit and lymph nodes. And again, I would like to emphasize the multidisciplinary nature of breast cancer care these days. So I really encourage you to talk with all your different cancer providers to see if this would be a fit for you. So I have said the word multidisciplinary a couple times, but what does it mean? Because there's been so much breast cancer research and the treatments for breast cancer have gotten more and more complex and involve more and more doctors from all different fields of medicine. You have your radiologist that does your MRIs, your mammograms, your ultrasounds. You have your medical oncologist who's prescribing you the chemotherapy. You have your breast surgeon. You have a plastic surgeon. You have a radiation oncologist, social worker, physical therapist, a nurse navigator. We have a cancer psychologist as well. So lots of different people collaborating in your care. So as you can imagine, having so many different doctors can lead to very fragmented care. So at El Camino, we actually have a tumor board every week where we discuss every patient's case so that all the providers are in a room together and we discuss it face-to-face so that we know all the special circumstances that are applying to that particular patient. And we really tailor each treatment to the patient's situation and scenario. We take it next step further by also having a multidisciplinary clinic. That means that a patient is able to come see us and all the different cancer providers in one clinic. Basically, it's a one-stop shop for the patient to come, and so they can see their providers, all the different providers in the same location at around the same time. I'm not saying that this appointment would only take an hour. You're meeting with a lot of doctors. It would probably take half a day, but at least you're getting all your answers. And studies have shown that a multidisciplinary clinic decreases the time from diagnosis to initiation of cancer treatment. Okay, so if there is one or two things that I hope you remember from this talk, it's that there's a lot of research happening in breast cancer, and it makes it a very dynamic and ever-changing field. Because of all this research, there's no one-size-fits-all in terms of the approach to breast cancer treatment. And in fact, treatments are becoming more and more customized to each patient's unique needs and cancer profile. And that's why it's really important, now more than ever, that all your breast cancer doctors are working together in a multidisciplinary fashion to create your treatment plan. Thank you.